members to live in a household. Then this is a thumb, which is a partially affected thumb, because we know that in leprosy, the fingers and the thumb or the limbs are affected. So this partially affected thumb is to emphasize that leprosy can be cured and a leprosy patient can be a useful member of the society, and they can contribute irrespective of their partially affected digits. The sun symbolizes that it is a symbol of hope and optimism. And why this symbol is there? Any idea? Why we have created this symbol, or what was the need of having this symbol? Students, you need to respond. To reduce stigma, correct. So leprosy is a disease which is associated with stigma, and one of the foremost objective of this program, one of the major objective of this program is to reduce stigma. And the goal of this program is as this is the name suggests, National Leprosy Eradication Program. The goal is to eradicate leprosy by the turn of this century. Aim is to reduce caseload to 1 or less than 1 per 10,000 population. So you can say that the aim is not to exterminate the agent totally, or the infectious agent. We are not planning to completely remove it from the global arena. What we are planning is to reduce the caseload to 1 or less than 1 per 10,000 population. So why this is the situation? That though the program name is eradication, our goal is eradication, but we are aiming to reduce the case burden. Any responses? Hope my question is clear. Students, you need to respond. No responses means that I'll be skipping this question. Any responses that why, if we are targeting the disease, we are planning to eradicate the disease, still we are looking to reduce the caseload to 1 or less than 1. And we are not planning to eradicate it like smallpox, that there should be 0 cases. Okay, so this is your assignment, because I think you people are still not ready, prepare for the class. You are quite kindly get back with this assignment. Okay, so the objective is, and I'll be giving more assignment in case you people are not responding. It is chronic, okay, and elimination is interruption in transmission. Yes, 1 in 10,000 cases need to be reported, okay. So because it is a chronic disease and the incubation period may last up to 10 years. So we are exactly not sure that if we say that agent doesn't exist in this, agent doesn't exist anymore, whether we can rightly claim that, because with the long incubation period, we cannot make such a claim. Therefore, the idea of the program or the goal of the program is to eradicate leprosy, but the aim is that the caseload should be reduced to 1 or less than 1 per 10,000 population. So the agent still may remain in environment, but the burden of cases need to be reduced. Objectives is elimination of leprosy. So you can see that there is a discrepancy. Goal is to eradicate, while when we are talking about objectives, we are discussing about the elimination. And elimination means that prevalence or the burden in society should be less than 1 case per 10,000 population. Second objective is to strengthen disability prevention and medical rehabilitation. So as you rightly made out from your from the first slide, that leprosy leads to a lot of disabilities in form of affected thumb, in form of nodular deformities. So one of the main objective is to strengthen disability prevention and rehabilitate the person. And third is to reduce the level of stigma. Now, these are the components of National Leprosy Eradication Program. First component is decentralization of the services. What do you mean by decentralization? Any idea? Please speak. Please let me know in the chat box what is your understanding of decentralization. We keep saying कि decentralize कर दो, COVID services should be decentralized, non-communicable disease services should be decentralized. What do you mean by decentralized? Any responses will do. So please respond. What do you mean by lower levels? Local government should take over various levels, okay? So what is the lowermost level of healthcare delivery system? Correct. So it is PSC, CSC level. So when we say decentralized of services means that the leprosy services should be available at PSCs and CSCs. We don't want people to rush to hospitals and tertiary hospitals for their treatment and diagnosis. Similar strategy we have now adopted in COVID, that wherever possible, we are providing testing services. So a patient need not move very far away from their house for diagnosis. So decentralization is one of the key strategies in almost all the programs, that patient should be made available diagnostic services and treatment services as near to their household as possible, so that their movement is, so they need not move far away from their place of stay, and otherwise it will lead to loss of compliance and poor testing. So in case of leprosy also, one of the major component is decentralization of the leprosy services. And second component is integrated. Integrated means that we want these services to be integrated with general healthcare system. General healthcare system, you understand that at PSC level, almost all the common diseases are treated. One of the major strategies in PHC or primary healthcare is to provide treatment to common medical illness. And under National Leprosy Eradication Program, one of the major strategy or component is that leprosy services should be integrated with general healthcare system, so a patient can easily avail these services at PSC level. Second is capacity building of all general health services functionaries. So if you want to integrate the services at general healthcare level, then all your doctors, all your nurses, and all your healthcare staff should be trained in diagnosing and treating leprosy. So second component is related to first one, that first you will decentralize the service, and second is that you will build their capacity. And third is intensified information, education and communication, IEC. That is a essential step in almost all the programs, that people need to be made aware of common signs and symptoms, so they themselves report at the PSC. And why you want people to themselves report at the PSC? Why you want that people should themselves come to the PSC? What level of prevention we are targeting when we want people to themselves come to the PSC with the signs and symptoms? Responses, student, what level of prevention we are targeting? Anamika, Satvik, Divyansh, okay, secondary, very good. Early diagnosis and prompt treatment, yes. So early diagnosis can be only possible when people themselves come up with their symptoms and seek care. Unless they come out to seek care, it will inevitably lead to delayed diagnosis. And as you know, in leprosy, there is hypopigmented patches to start with, or thickening of nerves. So these are signs and symptoms which will not cause trouble to the patient. So IEC is very essential that they should know that hypopigmented patches, hypoaesthetic patches are early signs of leprosy and they need to report for care. Okay. Then fourth component is prevention of disability and medical rehabilitation. So this is what level of prevention? Prevention of disability and medical rehabilitation. Tertiary, very good. And intensified monitoring and supervision. So very good. So now you know that these are components, 5 components of NLEP, and they are easy to remember. Number 1, you want all the patient to get services at the PSC level or nearest to their house. Then you want all the healthcare staff to be trained by capacity building. You want all patients or all community members to be aware of the leprosy signs and symptoms through intensified IEC. Then you want a system in place where disability can be prevented, or for people affected with leprosy, medical rehabilitation can be started. And fifth component is intensified monitoring and supervision, that whatever you have planned or whatever strategies you are considering, it should be monitored and supervised. So these are 5 essential components of NLEP. And these are similar in almost all the programs. Everywhere we want our healthcare functionaries to be trained, IEC to be there, prevention of any complications, and monitoring and supervision. So these are general components in any program. Coming to leprosy eradication program, in 1955, Government of India launched this as a national leprosy control program, and only monotherapy was utilized. Dapsone was the drug or the magic bullet which was used for leprosy patient. In 1970, though the MDT cure was identified, multi-drug therapy was identified, but it was not included in the national program. And national program remained with Dapsone. Only after 12 years, by recommendation of WHO, MDT was integrated in National Leprosy Eradication Program. So though 1970, the MDT was diagnosed as the effective cure for leprosy, but it took 12 years for national program to integrate it in the for the leprosy cure. So there was a huge time lag, and therefore you might now understand that why research done at any level need to be made available for policy implementation earliest possible. This you are seeing at COVID situation also, that whatever research is happening, we want our healthcare practitioners to put it in practice earliest possible, and therefore dissemination is essential. In 1983, National Leprosy Eradication Program was launched. And why it was launched? Because it was realized that MDT provides an effective cure to leprosy. So with that confidence, National Leprosy Eradication Program was launched to arrest the disease activity. A word about multi-drug therapy. You might be already aware that MDT is a combination of clofazimine, rifampicin, and dapsone. So it includes 3 drugs. And the treatment lasts from 6 months to 12 months. How many types of leprosy you are aware of? How many types of leprosy you people are aware of? 5 types of leprosy. Okay. And in case of program, this is okay. This is from Dharma, but at program level, how many? Yes. So at program level, it is just 2 types. This is to make out the kind of treatment that you will be giving them. So this is possibacillary and multibacillary. Okay. So at program level, to keep things easy, leprosy is only categorized into 2 types. And the idea was that multi-drug therapy, it is a very safe therapy, and it can be given by even ASHAs and AIIMS. MDT is available free of charge from WHO, and the first dose of MDT kills 99.9% of leprosy bacteria, thus eliminating the contagiousness of the disease, and therefore thereafter there is no need to segregate the affected persons. And the leprosy patient, thus who have been administered the first dose of MDT, and they are compliant to their treatment, they do not pose any threat to people around them. So all these points need to be made very clear to the family members of leprosy patient, so the patient doesn't suffer from stigma, isolation, negligence, social outcast, and all this can be prevented. That in case patient is getting started on treatment, the compliance of treatment will ensure that there is no further spread or there is no danger to family members. Further, upon completion of treatment under MDT, relapse of leprosy is rare, but the black line or the dark spot is the existing laws. They do not capture this development, and they are from medieval era. They continue to discriminate people affected with leprosy from coming into contact with unaffected persons, irrespective of their history of leprosy or whether they have been cured by MDT. So though there is advancement in research, there is advancement at program level, at implementation level, but majority of our laws have not included this advancement, and at times leprosy patient, leprosy children, they continue to suffer negligence and social outcast. And for your information, multi-drug therapy is a short note for you people. It can be asked in short notes. So just understanding that what kind of discriminatory laws are still existing. So there is a law where children affected by leprosy, they are not allowed to enter educational institutions. So this law was challenged in Supreme Court in 2014, and final ruling is still awaited. So it is a very recent happening. Second, in another petition, Supreme Court asked Chief District Medical Officer of Mayurbhanj, Odisha, to issue certificate which clearly state that the applicant have recovered from leprosy. So there was a patient of leprosy who had recovered from leprosy by taking MDT, but he was still facing discrimination during at his employer level or when he was seeking out employment, and Supreme Court ordered Chief District Medical Officer to issue certificate that he is recovered from leprosy, that he has recovered from leprosy. The final order is still awaited. So in both the cases, you can see that irrespective of the advances made, leprosy patients are still facing discrimination. So what are the strategies? We have already discussed these strategies, just a detailed understanding. Integration of leprosy services through general healthcare system. So through decentralized approach and capacity building of health functionaries. Then second strategy is early detection and complete treatment of new leprosy cases. So early detection, how you will reflect early detection is happening. So there is an indicator, new case detection rate. So to emphasize that we are able to detect the cases early, there is an indicator, that is annual new case detection rate, which is one of the major indicator for program monitoring. So if this indicator is static, not fluctuating or decreasing, then we know that our program is not functioning properly. And second major indicator is treatment completion rate. So these are two major indicators to review our program effectiveness. Third strategy is carrying out household contact survey for early detection of cases. So though we want people to themselves report to the healthcare services, but household contact by ANM and ASHA is one of the important strategy for detection of cases. Fourth is involvement of ASHA in detection and completion of treatment of leprosy cases on time. So both need to be emphasized, not only detection, also completion of treatment. So ASHAs are given this responsibility of searching for suspected cases of leprosy, following up them for completion of treatment, to motivate them for self-care practices and for spreading awareness. And there are certain incentives to ASHA, like it is ranging from 400 to 600 rupees if a patient completes the treatment, and in case there is a visible deformity, early case without any visible deformity, then 250 rupees, and new case with visible deformity, they get 200 rupees in case they are able to report this. And on confirmation of diagnosis, 250 rupees. So there are certain incentives to encourage ASHA workers. Then second objective was strengthening of disability prevention and medical rehabilitation services. So PSCs and at higher level, district hospital, dressing materials, supportive medicine and ulcer kits are advised, and they need to be provided to leprosy affected person. Any idea that Rajasthan has comes in high endemic zone or low endemic zone for leprosy? What is the burden of leprosy in Rajasthan? Students, are you with me, or you have like, it is high? Okay. Any reason why you say so, that it is highly endemic? Have you seen leprosy patient in your OPDs and derma OPDs? Have you seen any leprosy patient in your derma OPD or in your field setting when you have gone to community practice centers? Okay, so yes, there are colonies of leprosy patients in Jodhpur. Ankita has said this. And where are these colonies? How many colonies have you seen? Okay, so I don't know, there is no response thereafter. So colonies of leprosy patient. So now you can make out previously went through a school trip, great. So previously the leprosy patients were literally thrown out of their home and they were made to stay in separate colonies where only leprosy patients were staying. Now this practice is abolished and no more colonies, like there's no there's no guideline. There might be families of leprosy patients who are staying in those areas which was previously earmarked to them, but now government does not earmark colonies for leprosy patients anymore because cure is available and they are not, and the strategies not to throw them out from the mainstream society, right? So previously the discrimination was so much that the leprosy patient was thrown out and they were made to stay outside the village or at the suburbs area along with other leprosy patient, and they were totally outcast from that particular mainstream society. So it is just an understanding that what are the strength of this program. So now we know that we want easy access, reduce stigma, patient to be more compliant. But what are the challenges? Challenges is that we need to concentrate a lot on capacity building, because if leprosy burden decreases and there's imagine someone, I'm not sure how many of you have seen leprosy cases, but as the leprosy burden is decreasing, doctors and nursing staff, they are not aware how to diagnose a leprosy case or how an hypopigmented patch will look like or how to test a hypopigmented patch for hypoesthesia. So these are essential skills which our healthcare staff is lacking as the burden is decreasing. So if they lack these skills and suddenly a patient of leprosy reports to them in their PSC setup or in their clinical setup, they will be unable to detect the leprosy case. And they might end up giving them certain steroids and all, which will be all the more harmful to the patient. And undetected cases will later land up with the complications, will keep spreading the leprosy in the community, and it will be difficult to target the burden then. Similarly, there could be drug reactions, lepra reactions, and it requires a certain level of competency to manage these reactions. So all PSC medical officers might not be in a position to manage this kind of reactions. Okay. Then the stigma is still there, and there are certain hard to reach areas, and district level monitoring is essential. So it is just to give you an understanding that what are the challenges, even though our strategies are well placed, but there are challenges which will keep compromising the advancement we will make with the decrease in burden of the cases. Now coming to targets, what exactly we want to achieve through National Leprosy Eradication Program. As we have discussed, we want our prevalence rate to be less than 1 case per 10,000 population in all the district. So district is the main level which we are targeting at. So it is not at the state level. Previously it was at state level. Now it is at district level, that burden should be less than 1 case per 10,000 population. And as I already told you, that annual new case detection rate is a strong indicator for program monitoring, that how many new cases are getting detected every year. That indicator is less than 10 per 1 lakh population in 642 districts. So 642 is the total number of districts in country. Okay, so it is not like we are planning to increase in other districts later. It is the total number of districts, and annual new case detection rate should be less than 10 per 1 lakh population. Cure rates, the multibacillary, we want to achieve more than 95% cure rate, and in possibacillary, we want to achieve more than 97% cure rate. And disability and stigma. So grade 2 disability is severely compromising state where person loses their digits or they are unable to see, their corneal ulcers are present. So we want to minimize grade 2 disability among new cases by 35% and 50% reduction of stigma. So these are the targets for National Leprosy Eradication Program. Now, and a basic understanding that what is this mechanism, how National Leprosy Eradication Program functions. So we will go from bottom to up. So bottom, you all know that at village level there is Asha and Anganwadi worker. Then there is sub-center where village health and sanitation committee is operationalized. Then there is PSCs and CSCs where block Swasth Samiti is formed. Then there is CSC with Rogi Kalyan Samiti, and then there is district hospital. So this is essentially same for all the programs, but above district there is chief medical officer, state coordinator from WHO, and state coordinator from International Leprosy Eradication Program. So leprosy is a heavily funded program, and WHO and ILP societies are funding the leprosy treatment and diagnosis. Then it is integrated into NHM through state leprosy cell. So state health mission is seeing leprosy is integrated as part of NHM, and then there is National Rural Health Mission where there is a division known as Central Leprosy Division, and it operationalizes all the activities. So National Leprosy Eradication Program is a centrally sponsored health scheme, and mostly the organizational structure is same, but you need to know that it is funded by WHO along with Government of India. So what we are expecting, this is from your PARC. So you can refer to your PARC, it is just for general understanding. What we want at sub-center, we want that at sub-center level, we can advise our patient related to self-care, and we can tell them that where they can get the reconstructive surgery done in case of affected digits. And in case there is a reaction or disability, where to refer them. At PSC level, if possible, manage reactions or refer them to district hospital, providing microcellular rubber footwears for leprosy patient, practice self-care practices to be advised. So basically it is the essence of diagnosis which is sub-center and PSCs are supposed to play. Most of the treatment after MDT, so if patient have any reactions due to MDT or if there is any disability, it is managed from district hospital and above. So at district hospital, management of complicated ulcers, management of lepra reactions, and difficult cases to reconstructive surgery center. Then there is a district nucleus where like multiple districts, they are combined to form a district nucleus, and then similar thing need to be strengthened. And then there are special reconstructive surgery center where reconstructive surgery is taken care of, and mainly orthopedicians and PMR department. They are the major departments to contribute in this reconstructive surgery centers. So this is related to burden of leprosy. So you can see that in 2004, burden was pretty high. It dropped down to 0.84 prevalence rate in 2 years. But thereafter, burden has almost remained static. Any idea that why the burden is static? Why the prevalence rate is static? It is not decreasing, it is not increasing. Even the new case detection rate is static. You can see for last 5-7 years, both these indicators, prevalence rate and new case detection rate, they are almost static. Any feedback to share why this is happening? I think we have again lost our students. Students are there, or they have just, they are now busy with other activities? Can we have some responses? No idea, ma'am. Okay, so Satvik says no idea. Anyone else who has any idea that why the prevalence rate and new case detection rate is not changing? I think only few of the students are responding, so they are only eligible for attendance. So even if you don't have any idea, you need to communicate. Long course. Okay. What else? This you must understand, you know, why we want you to know this, because when you say ki this need to be taken care, this need to be taken care, then how you will say that this has been taken care of, whatever you are saying. If you say ki COVID ke burden kam ho raha hai, COVID is increasing, COVID is decreasing, what exactly you are seeing, and if there is static number of cases in COVID, then what you will suspect? So data should speak to you, like data, you should be able to interpret that what exactly data is indicating. So in this graph, if the burden is not increasing or decreasing, what exactly you suspect? Tell me. Only Ankita, Anamika, Satvik is with us, is with Archit is also there. Great. Anyone else who is there? Less survey. So very good, Anamika. So the less survey, less reporting, yes. No. Cure rate is equal to number of new cases, no. So when the program stops functioning effectively, when people, they get casual about a disease, then the burden gets static. Because as I told you, leprosy is not a disease where people will rush for treatment. Okay. So they will keep sitting at their places. They will not be in any hurry to get themselves treated unless the complications set in. So it is almost like COVID, that people will keep the disease to themselves. They will spread it among their family members, to their community, and they will not report unless it has really affected them and they are in complicated phase. So similarly with leprosy, the prevalence rate and the detection rate is static because people have got casual about the disease. There is less reporting. Government functionaries are getting casual about the disease, and the program is getting demotivated. The program management is getting demotivated because it is like you have to reduce the burden to less than 1 per 10,000 population. So you need to be so active that you are able to detect a case, 1 case in 10,000 population. And this is a real committed task. So why don't we start door-to-door case detection? So door-to-door case detection is included in the leprosy program, and the Ashas and Anganwadi workers and the AIIMS, they are the major functionaries. But as you know, they are the major functionaries for all the programs. right? So like it is some of the functionaries, they are heavily burdened, and then it becomes mainly to the program management, that how active program management is. So if such a situation is happening, then we took a new indicator or a different indicator to understand that what is happening at the program level. And the other indicator was grade to disability. So I'll show you. Look at this map of country. So as per the country map in 2016, only 2 states were having high burden, where the prevalence rate was more than 1 case per 10,000 population. So this shows a very good picture that we are targeting less than 1 case per 10,000 population, and we have achieved almost in whole of country except for Chhattisgarh and Odisha. But look at this map. This is grade 2 disability, and grade 2 disability will only set in when there is long period of negligence, like patient has kept the disease to themselves, and only after disability they know that their digits, they are getting affected, their foot drop is present, corneal ulcers are coming up, then only they have come to the health facilities. So in those cases, grade 2 disability gives a clear picture that what is happening at the program level. And you can see that there are so many states where grade 2 disability is more than 5. So we are targeting grade 2 disability of less than 1 per million population, but it is more than 2 per million population in almost 28 states. So now you can understand that what is exactly happening at program level. The prevalence rate and new case detection rate is not increasing. What is increasing is grade 2 disability, because there are so many hidden cases. And this is one of the ways you look at the indicators, that when your health functionaries are not reporting you correct data, then you need to find out that what is happening at the field level. Okay. So in 2015 and 16, a boost, there was a change in program management and lot of active survey was started. So it was realized that one state, Chhattisgarh and Odisha, and one more union territory, Dadra and Nagar Haveli, they are remain to achieve elimination, and 4 states, they are reporting more burden as compared to previous years. These 4 states were Odisha, Delhi, Chandigarh and Lakshadweep. So Delhi and Chandigarh were real surprise for program managers that they are reporting prevalence rate more than 1 per 10,000 population. And why this was happening? Because these are those states where lot of migrant population is present, right? So this is essential understanding that you should have about a program, that program indicators need to be reviewed. What you are getting, what reports you are getting, you need to see that exactly what those numbers are telling you. Your health staff might not give you correct numbers, but you need to make out as a learned person that how to cross check or verify those numbers, right? So this is the way we can see that National Leprosy Eradication Program was not making real good progress, irrespective of this graph, that where this graph was showing that the burden was static, but we know that grade 2 disability burden was increasing, and therefore the burden as such of the disease was increasing. So I have already told you that new case detection rate and treatment completion rate are one of the major indicators, and other indicators are grade 2 disability rate and child affected with leprosy, because again you know that proportion of child who are affected with leprosy, if it is more. So leprosy is a chronic disease. So if children are getting affected with leprosy, again it shows that leprosy is prevalent in that state or in that district. So imagine there are 11 states where proportion of children cases is more than 10%. They form more than 10% of new cases. So you can imagine that actually leprosy is far from eradication or elimination. Only we now have hidden cases which now present to healthcare facility as grade 2 disabilities or in form of affected children. So now coming to global level, that what is the global scenario? You are aware of sustainable development goals. In goal 3 is related to health, and target 3.3 is that by 2030 sustainable development goal target to end epidemics of AIDS, TB, malaria and neglected tropical disease, and leprosy is one of the 18 neglected tropical disease mentioned. So at the level of global commitment is there, and it is huge that by 2030 they want to end this epidemic. At the level of national commitment, if we talk what is the national level commitment, even National Health Policy 2017 have declared that it, they need to achieve and maintain elimination status of leprosy by 2018. So you know that in terms of prevalence rate, they have achieved that we have burden of less than 1 case per 10,000 population. But what exactly is happening is more cases of grade 2 disability and more number of children getting affected. So it is exactly not the true picture of leprosy disease. Then the second indicator is reduction of grade 2 disability to less than 1 per million by 2020. And you can make out that what is the situation here? Grade 2 disability is rampant. It is more than 2 per million in almost 28 states. And in few states, it is more than 5 or 15 even. So the burden is still huge. And then grade 2 disability among new cases will be the measure of community awareness and health system capacity. So what program managers are now focusing is at not at prevalence rate or new case detection rate, but at grade 2 disability, because grade 2 disability is difficult to hide. Patients will definitely come to health system if they are suffering from disability, and the health services or the health staff cannot hide grade 2 disability. This is the commitment from WHO, that WHO says they need to strengthen government ownership, coordination and partnership. Leprosy need to be stopped along with its complications. So it is similar to our objectives. What are the objectives of National Leprosy Eradication Program? So you need to be aware that in National Health Policy, what are the main criteria for leprosy, and what is the difference between prevalence rate, new case detection rate and grade 2 disability, and how grade 2 disability is helping us to understand what is happening at the program level. Any questions? So this is the end of my lecture. Any questions, student? I think we have lost everyone. Students, any question, please ask. Anything you want me to repeat? Thank you. Okay, no, so Satvik is the first one to respond for no queries. I think he is representing whole of class. Thank you, Archit. Okay.
Didn't come. Yeah. I thought you already left. No, he didn't come. 1.1.2. 1.1.2. This is clear. Wait. Really, it's 40. Which person? Almost normally. It's not normally. क्या खाना
3.5 to 5.5 potassium. 3.5 to 5.5 phosphate. I think so.
This is audio, huh?
What is it?
Is it on? Students, can you see the screen and am I audible? Right, right. So today we'll present about the hoarseness of voice. Hoarseness basically. Is it okay? Settings are okay? Screen is clear? Is it clear, students? Okay. So there will be class regarding the quality of voice today, and the topic is hoarseness and benign mucosal fold diseases, disorders. So first, what is hoarseness? First of all, it is not hoarseness of voice, it is hoarseness. It's change in quality. As you can see in this picture, it is the perceived breathless quality of the voice, according to Bailey. And Dorland and Stedman has different version of this, that a rough or noisy quality of voice, a rough or harsh quality of voice. I hope if you come in the OPD, you can listen. These patients come to us with the growth in the vocal cord, with the hoarseness, change in the quality of voice. That indicates that there is some problem in the speech production, change in voice, hoarseness. It is basically, it is not a disease. It is actually a symptom. Just like a fever, when you treat fever, but you go to the root cause of the fever to know why this fever is there. Similarly, hoarseness is a symptom. We need to find out, investigate, and reach the root cause of hoarseness and treat accordingly. Although it is a part of this diagnosis in ICD-9. So in brief about the anatomy, you can see in this picture. As we all know, this is a picture that we have hyoid bone in superiorly. Then we have cartilages, thyroid cartilages, which is not completely encircling the airway. And this is the cricoid cartilage. It is a cartilage with a ring shape, which completely encircles the larynx and all these areas. And it is the behind, this is the anterior view, this is the posterior view. This is the posterior view, this is the epiglottis, leaf shape with small fenestra. This is arytenoid, corniculate, cuneiforms, small cartilages. These are accessory cartilages. There is a small one, this is cuneiform. Then this is a cricoid cartilage. Anteriorly it is like this and posteriorly it is like this. It is broad, it is more broader there in the posteriorly, and this is the this is a cartilage. And then right down it is a trachea. Trachea, we have all cartilages C shape. It is there, they are present only anteriorly, not posteriorly. So this is the anterosuperior view. As we can find, here is मेरा side में So this is regarding the and between, this is a membrane which is between the hyoid bone and the thyroid cartilage, the thyroid membrane. This is the membrane between the thyroid cartilage and the cricoid membrane. This is a cricothyroid membrane or ligament. This is thyroid membrane. Through this membrane, all vessels and nerves passes, like superior laryngeal vessel, nerves, or everything. This is the AP view. As you can see, this is a arytenoid. This is cricoid cartilage. This is cricoarytenoid joint. This is arytenoid cartilage. Both. These are the corniculate and cuneiforms, and the joint is known as cricoarytenoid joint, which is the most very important joint. These have two processes. This process is known as vocal process. This is known as muscular process. Vocal process gives attachment to vocal cord, and this is a muscular process which gives attachment to muscles. All muscles of the larynx, a lot of muscles of the larynx attached here. These are the two processes. This picture seems to be complex, but it's very easy to understand. This is the epiglottis. This is a leaf-shaped structure. Petiole, it's all known as petiole. As you can see, this epiglottis attached to hyoid bone through the hyoepiglottic ligament and through the thyroid bone, thyroid cartilage, through the thyroepiglottic ligament. This is the epiglottis. Here you can see this is the arytenoids. This is a vocal process giving attachment to vocal cord, which is going and fixing to the thyroid cartilage. And these are the lateral, and this is middle section. And this is the cricothyroid membrane. This is regarding only this thing, thyroid membrane. Now, see the structure posteriorly and lateral view. In lateral view, you can see there are different muscles. So we need not remember and learn all the muscles. Okay. So one of the most, just for a presentation sake, I will let you know, these are the aryepiglottic muscles between the arytenoids and the epiglottis. Between the epiglottis and the arytenoid, this is the aryepiglottic, right and left. These are the two, this muscle is transverse arytenoid muscles between two arytenoids. Transverse arytenoid muscles. This is posterior cricoid. The name all itself suggests between the cricoid bone and the arytenoid. These are posterior cricoid muscles. Similarly, this is the cricothyroid muscles between the thyroid cartilage and the cricoid cartilage. This is the cricothyroid muscles. This is the superior view. This is the most important structure, most important diagram we should know. See, the main purpose to learning this muscle is not to just memorize it. Our main purpose of presentation this muscle is to let you know the muscles which are important in speech production. So here, look at this diagram. This is which muscle? This is between the two arytenoids. Transverse arytenoid muscle. There are some oblique muscle. These are the muscles. See, this is the vocal cord going like this. This is known as, this white structure is vocal ligament, and the muscle is vocalis. This is the vocalis muscle. And this is one of the vocalis muscle and thyroid muscles. So the muscles which are in the vocal cord and very important for speech production is two muscles. The first band is vocalis muscle, and the other band is thyroarytenoid, between the thyroid cartilage and the arytenoid. These two muscles form the bulk of the vocal cords, which are important to learn this thing. Okay. These are regarding the nerve supply. As we all know, all nerves, these are the nerves. This is the superior laryngeal nerve. This is a vagus nerve. Vagus nerve has a branch of, this is superior laryngeal nerve. Superior laryngeal nerve gives two branches. Superior laryngeal nerve is itself a branch of vagus nerve. Superior laryngeal branch gives two branches, internal laryngeal nerve and external laryngeal nerve. Internal laryngeal nerves enters to the larynx through the thyroid membrane, and external laryngeal nerves, it passes through it supplies the cricothyroid muscles. Basically, internal laryngeal nerve is a sensory nerve. Above the vocal cord, all the sensation is supplied by the internal branch of the superior laryngeal nerve, and this nerve supplies the cricothyroid muscles. And here, this is the Recurrent nerve. This is also a nerve of vagus. It's a recurrent nerve. It comes back from the chest and it supplies all the muscles. It is a sensory below the vocal cord. Above the vocal sensory is internal and it supplies all the muscles. So basically all the muscles except cricothyroid is supplied by recurrent laryngeal nerve. Superior laryngeal nerve is a branch of vagus which gives two branches, internal and external. Internal is sensory, external is motor to cricothyroid. So what is the action of cricothyroid muscles? Cricothyroid muscles, it causes the tension. It causes the increase in lengthening of the cricothyroid muscles. Cricothyroid muscles and causes the increase in the tension, increases the lengthening of the muscle. As we all know, so this is the structure. So anatomy is, the vocal cord has three functions basically: abduction, adduction, and rotation. Okay, main is abduction and adduction. So this is the adduction when vocal cord meets in the midline. This is the complete adduction of vocal cord. So action of vocalis and thyroid muscle is shortening, relaxation of the vocal ligament. So this is the adduction of the vocal cord. In adduction of vocal ligament, vocalis and thyroid, they relaxes, they shortens, leading to collapse, coming the adduction of the vocal cord. In abduction of the vocal cord, it is a function of basically posterior cricoarytenoids. Posterior crico, between the cricoid and arytenoid, posterior cricoid and arytenoid, it leads to abduction of the vocal fold, vocal ligament. That was regarding the muscles. So what is the relevance of this? The relevance is when there is some involvement of these muscles, because either nerve supply or muscles involvement, like we do in, suppose we do a thyroid surgery and there is a resection of the nerve, recurrent laryngeal nerve, then these patient can present with hoarseness, or if there is some tumor which has gone and infiltrated these nerves, recurrent laryngeal nerve, even then patient may have different problem depending on which nerves are involved. So regarding the histology of vocal cord is very important regarding this. As we all know, it is a three-layered. It is a consist of outer layer is lamina propria and inner layer is muscles, vocalis and thyroarytenoids. So which lamina propria, it is the most important structure which has a very, very important role in speech production or proper speech production. The first outer layer, middle layer and deep layer. Outer layer is known as superficial layer, intermediate layer, and then there is a deep layer. So this is the structure. Outer layer, it is known as epithelial layer. Then there is a lamina propria. Then there is a lamina propria. As you can say, this is epithelium. Epithelium is basically pseudostratified squamous epithelium, as we all know. Then there is a lamina propria. Lamina propria has three layers: superficial, intermediate, and deep. So superficial, intermediate, and deep. So what is the significance? Intermediate and deep, it is also known as vocal ligament. So intermediate and deep is vocal ligament. These are made up of gelatin, proteins. Outer is gelatin, inner is proteins, and it's epithelial layers. And these are so there is usually a space between the superficial layer and the intermediate layer. That is known as Rinke space. And then Rinke space. Between the superficial and intermediate layer, there is usually a space that is known as Rinke space, and that has a very important role in, there is a disease called Rinke's edema. We'll discuss it later. And these are the structure. These are the vocal cord. These are the vocal ligament. These are the muscles, muscle fiber. So student, there are three layers. Outer is epithelial layer. Middle is lamina propria, which may be divided into superficial, intermediate, and deep. Between superficial and intermediate, there is a Rinke space. Intermediate and deep is known as vocal ligament. And behind it, there are two muscles. First is vocalis, and there is thyroid, which are important, which relaxes, and which are important for speech production. So these are regarding the histology of this thing. Now, what are the functions? Functions of larynx: prevents aspiration, respiratory gateway, phonation, valsalva, When you lift up a weight, if there is a abduction of vocal cord and there is a positive pressure, you may transmit this positive pressure. If there is a problem, the vocal cord is not able to approximate, it will be very difficult for you to lift any weight. That is known as Valsalva. So phonation is a very important function. So how do you phonate? It is the larynx is basically recognized as a critical organ for sound production for centuries. There are different theories. Person has presented the neurochronaxic hypothesis in 1950 that each vibratory cycle caused by separate neural impulse, but these are regarding the history. The current receptive mechanism is body cover theory. We'll discuss it now. The first is interaction of aerodynamic forces and mechanical properties of laryngeal tissue generate vocal sound. That is the accepted mechanism, that there is a interaction of the tissues, different muscles, according to depending on the flow of the air that forms the sound. So this is the cover, this is the body. Cover is superficial and lamina propria, and body is muscles. The requirement for phonation is there should be adequate breath support, approximation of the vocal cords, favorably vibratory cycles, control of length and tension. So what is the mechanism is? So when you inhale air, there is a glottic closure. And exhalation increases subglottic pressure until vocal cord displaces laterally. So when there is inhalation of air, there is a vocal cord, and when patient is trying to expiration, it started building up a pressure below the vocal cord. And gradually this vocal cord opens and air passes through it. After some time, again it returns to the midline. So this is actually the principle is ground is Bernoulli effect of airflow. So the concept is body cover concept. Body cover concept is that there is a vibration of the mucosa does not correspond directly to the vocal fold. Wave is propagated usually along the mucosa. It is made possible by Rinke space, which is gelatin-like layer made up of loose connected fiber of collagen and elastin. Vocal ligament, which is made up of does not undergo mucosal wave. So basically what they are trying to say, that usually the epithelial layer and lamina propria superficial layer, it basically vibrates. Intermediate and deep layer, they does not vibrate. This is like a dress over your body. When there is a wind, only your dress moves. It basically moves, but your body doesn't move. So basically, these are the structures, epithelial layer and lamina propria superficial layer, which undergo vibration for speech production. These layer does not undergo these changes, although they move and close simultaneously. So this is the reason that we have different speech for different persons. This is you can see this when there is a aspiration starting, that outer layer, that is the posterior part of the vocal cord, they start separating first and anterior part separating later. Moreover, the opening of lower part of vocal cord open first and superior part open last. Similarly, closure also, this part open first, this part open later. This is like a wave. The first wave, second wave, third wave. I know it's difficult if you have any doubt, but just learn it. Cover and body cover concept. Cover is cover and body. Cover, body, cover concept. Cover is your superficial layer of lamina propria and epithelial layer. Body is your vocal ligament and muscles. So if a person comes to you with hoarseness, history should be regarding the onset and duration of the vocal symptoms. What are the potential causes or exacerbating influences? How much does it talk? That is a very important implication, especially in teachers. Other risk factors are tobacco use, alcohol, LPR, that is laryngopharyngeal reflux, dehydrations, medications, allergies. So the first thing we do is examination of the vocal cord. You need to see the vocal cord. Although we have different modalities, you can use any modalities to make a diagnosis. The first modalities and foremost And a very conventional technique is laryngeal mirror. And I hope everybody of you must have seen in the OPD. Laryngeal mirror is a fast, inexpensive, minimal equipment use, but the disadvantage is a gag reflex and is a known physiologic, known permanent image capability. You cannot preserve the record that yes, you have seen it. It is a very subjective test. You cannot show it to someone else. You cannot record it. A rigid laryngoscopy, that is through the 70-degree or 90-degree telescope, we usually do in our OPD. Advantages are best optic image, magnifies video document. You can make a video also, and you can just you need not disturb. You need not ask the patient to undergo examination again and again. You just examine the patient, make a video recording, and just show it to your seniors or your other colleagues to get an opinion. But the disadvantage is a gag reflex, non-physiologic, and it is an expensive technique. So this is a flexible fiber optic nasolaryngoscope. The advantage is that these are well tolerated. It is a nasolaryngoscope. It passes through the nose. It is a physiologic. You can see while the patient speaks, while the patient is in a normal physiology. You need not ask the patient to open his mouth, pull out the tongue and say, ah. You can do a audio documentation. The disadvantage is that it's a time consuming. It is an expensive. This instrument costs in lakhs. The resolution limited by the fiber optics. So these are basically three techniques. Video stroboscopy. This is a very good technique to know the basic problem. It allows you to have an apparent slow motion assessment of the mucosal vibratory dynamics, video documentation. But the disadvantage is the time consuming and expensive. The other three technique, they does not show you the mucosal vibratory dynamics. But this videoscopy has a potential to show you whether there is what are the pattern of the mucosal vibration. For example, in laryngitis, chronic laryngitis, when there is a fibrosis, there will not be any mucosal vibratory dynamics. So that you can predict a basically prognosis and you can make your treatment plan accordingly. Now this is a little bit more, you can say, you need to ask the patient to undergo general examination, general anesthesia. We can use the direct laryngoscopy, which is available for use. The benefit of this technique is direct laryngoscopy. You can do the make a diagnosis, and as well as you can make the intervention to treat it. You put this, patient is under GA, you put this inside the mouth, see the vocal cord, and through the hole you can do the intervention. So these are regarding the investigation parts. So there are a lot of benign lesions which leads to the hoarseness. So we have basically two things that we usually perform. The first is cold instruments, another is CO2 laser. So what do you mean by cold instruments? Cold instruments are basically our surgical instruments like forceps and all these things, forceps or scissors. We have a long forceps, long scissors for larynx. So if it is a less than 3 mm, we use cold instruments. For example, is nodules, hemorrhagic polyp, abscess, granuloma. 3 to 6 also, more than 6 also. Similarly, CO2 laser is the latest technique. It's used for all these items like polyp, granuloma, chorditis. So these are the cold instruments. You see the scissors, forceps, all micro. These are known as microlaryngeal instruments. Microlaryngeal, used basically for larynx because of their length. They are specifically made for intervention in the larynx. You can see the length of those instruments. They have different mouth according to the need of the surgeon to do the intervention. Then there is one more technique called subepithelial injection of the saline and epinephrine. Basically, it makes a difference, exaggerate difference of the normal superficial lamina propria from a polyp tissue and hematostasis. Basically, if you inject it, you can make an ideal difference between a polyp tissue and a normal tissue. And you need to preserve as much normal tissue during excision as much as possible because the quality of voice is entirely depend on the normal mucosal layer. So if you exercise a lot of mucosal layer, which is not required usually, it may lead to the change in voice, which may not come normal after the healing because of the fibrosis and other factors. These are different techniques, lateral microphlebectomy. I don't think you should undergo all these techniques. So the thing is, just for your orientation, this is we use a direct laryngoscope, and through this vocal cord, you can see this is a cold instruments, and this vocal cord vocal nodule is being excised. As in this technique, you can see that we give an incision and we elevate the mucosal flap below over the nodule, and we take out the nodule and we put the mucosal flap back to the where we have given the incision. These are the cold instruments. As you can see, there are different instruments are there. These are the scissors. This is a scissor, microlaryngeal scissors, and this is after the surgery. So basically, the technique is if there is a polyp over here, we give an incision like this. We elevate the normal mucosa over the lesion, elevate it, and these nodules and polyp they are in below this normal mucosal layer. We take out the nodule, we reposite the normal mucosa back to the where we have given incision, and it heals by itself. And there is an excellent quality of voice after this surgery. This is CO2 laser. The purpose here is just to give an idea that CO2 laser can be used. There are other techniques also like coblation, which can be used, radio frequency, but the best is laser or cold technique. So these are the few pathologies of benign vocal fold lesions like polyp, nodules, varices, cyst, granuloma, Rinke's edema, and papillomatosis. Most common is polyps and nodules. Less common is other structures like granuloma, cyst, varices, Rinke's edema, papillomatosis. We see a lot of patients who come to us with polyps and nodules because they have a history of voice abuse in the form of they are either teachers or speakers or politicians or singers who speaks a lot, or they speak in a loud voice, which leads to trauma over the vocal cord, and eventually they turn up to us with the diagnosis of polyp or nodule because they come to us with hoarseness. So polyp is typically the result of trauma to the superficial lamina propria and the microvasculature. Size, shape, and tissue composition is variable. It may be sessile or pedunculated. It may be vascular, or it may be fibrotic. It is commonly found in the middle portion of the mucoso-membranous region. See this. See this structure. Overlying epithelium is usually normal and can be preserved to some extent. So it is basically a problem in the superficial lamina propria. Above epithelium is usually normal. It may be without the branch, it may be pedunculated, or it may be sessile. It all depends. Initially, all polyp is sessile. As the time passes, it becomes pedunculated. It is not that there are two different types. It is just a time period when the patient present to us. Initially, all polyps are sessile. If you see in early phase, it is sessile. But if patient present to us late, these polyp keep growing, and at some point of time, they becomes pedunculated. It may be small, it may be medium, it may be large, depending on the size. And excision is usually done by the cold instruments for the small and the medium, and it can be, laser can be used for the large polyp. Reason being, it is usually vascular, and large polyp, they may bleed. So laser basically, it's not that you can't use cold instrument, you can use cold instrument for large polyp also, but CO2 laser gives you an advantage that it leads to no bleeding at all, and or very minutely bleeding, which may be more for a cold instruments, but then you should be experienced enough to use how to use the CO2 laser. So you can see this. This is a small polyp. It is sessile. It is not vascular. But see this. This is a polyp also which is sessile, but it is vascular. It is reddish. It is usually unilateral, seen in the middle segment of the vocal cord. This is a big polyp. It has become pedunculated. Pedunculated is it moves up and down during speech production. So this is a nodule. That was a polyp. This is a nodule. It is basically a fibrovascular tissue. It is not vascular at all. It is always fibrovascular. It is fibrous. So very less bleeding when we take out the nodules. Strobo-video-laryngoscopy. Stroboscopy is insulin assessment. It is thinned effective mucosal layer. The superficial lamella proprius becomes thin. The treatment is, if it is early nodules, patient has just come to you and you can see a small, very small nodule, you just ask the patient to undergo voice rest or vocal rehabilitation. We have a vocal speech therapy especially for this purpose. Patient nodule usually comes back to normal, but it becomes large, then the surgery should be done. It cannot be corrected by itself. As you can see this, these are very, very small nodules. Patient comes to us with a change in voice or hoarseness. You can see the basic thing is nodules are usually seen in anterior 1/3. They are usually bilateral. But in the other hand, the polyp, they are usually unilateral, seen in the middle 1/3. And nodules, they are bilateral at the junction of posterior 2/3 and anterior 1/3. Slightly large nodules. With slightly large nodules. Ectasia and varices, they are basically results from microvascular trauma. Usually patient doesn't come to us with a problem, very slightly, but if it is there, we need to do something with a cold instrument, so we need to take out that lesion or laser. As you can see this is a microvascular trauma, small bleeding point is there, it leads to the small. You can see this is basically a pattern of the microvascular. This is a nodule basically, N. Nodule usually look like this, but you can see on a picture there is a varices also. Cyst. This is the third most common diagnosis that we've seen in the superficial lamina propria. It is basically rising superficial lamina propria. It is attached to the vocal ligament. It is freely suspended within superficial lamina propria. Size is variable. It is asymmetric spheroid mass or middle surface of the vocal fold. It mostly arises from obstructed mucous ducts in superficial lamina propria. Cyst, it basically, there are glands. Whenever the opening of the gland is blocked, it leads to the obstructed mucus and which forms the cyst. Treatment is by the cold instrument or by the CO2 laser. You can see this cyst. This is cyst. And by the appearance, you can see this, it is from a superficial lamina propria. When you open it, you can see the cyst material is coming out. We need to excise it. This is usually unilateral. Granuloma. Granuloma is usually seen at the posterior 1/3 of the vocal fold. It results from hypertrophic inflammatory reaction due to traumatic mucosal disruption. It is majority found in arytenoid. See, all the other things are found in the anterior part of the vocal. It is found in the arytenoid region. Usually they are exophytic with narrow base, typically arise in patients with LPR, seen with endotracheal tube. These are the two patients which we usually, because the laryngopharyngeal reflux, gastric acid falls into the larynx and it is the posterior 1/3 in the arytenoid region, which is the area which is exposed to that gastric acid. And our larynx mucosa is very soft. It is not made up to expose to gastric acid. It leads to the disruption of the mucosa, forming the granuloma. Other group of patient is endotracheal intubation, because in prolonged endotracheal intubation, if the tube is not matching the size of the larynx, suppose the larynx is narrow and you have put the wide tube, patient requires 6 number tube and you put an 8 number tube, it will lead to the trauma of the mucosa in the larynx, and it is a posterior part of the larynx, posterior part of the vocal cord through which this tube passes. So this is the area through which there is disruption and granuloma formation. Treatment is vocal fold therapy and anti-reflux. The surgery should be done. Conservative management has failed. only then it should be gone for surgical resection. Sometimes it may turn malignant, although very rare. If there is a repeated exposure of the gastric acid, it may turn malignant. And if it becomes big enough, it may lead to the airway compromise. Then you need to do the surgery. This is an example of granuloma. You can see it is formed in the posterior part of the vocal cord in the arytenoid region. This is the other example of granuloma. Third example, after surgery. You can see small granuloma over here that can be managed with speech therapy or anti-reflux therapy in the initial part of the treatment. If does it fail, patient is having problem, do surgery. Now, other common thing is, it's not very common, but yes, it is there. If we see, occasionally we see these patients, these are Rinke's edema or polypod chorditis. There is extensive swelling of the superficial lamina propria, usually on the superior surface of the musculo-membranous vocal cord. It is not at the lower surface, it is superior surface. It is usually bilateral, but the asymmetric volume. There are a lot of reasons for this. Nobody knows what are the reasons. The main reason that we have found is it may be due to smoking, laryngopharyngeal reflux, and vocal hyperfunction. Smoking is persistently been found to be associated or related to Rinke's edema. So treatment is first is smoking cessation. All other reasons, all other pathology of vocal cord, smoking is not related. But in Rinke's edema, smoking is found to be related to formation as well as progression of the Rinke's edema. So we should take a history. If patient is smoker, ask him to immediately stop the smoking. We should give anti-reflux medication and speech therapy should be advised. Surgery, like there are surgery should be done. The surgery is different, in which we do epithelial microflap elevation with SLP contouring and reduction using either cold instrument, microscope, C2 laser, or both. Vocal ligament should never be visualized. Both vocal folds can be treated in one procedure if flap is elevated on superior surface of vocal cord. So the thing is, in surgery, what we do is, there is an edema of the superficial lamina propria. So, and it is basically on the superior surface of vocal cord. So what we do is, we give an incision over the vocal fold, we elevate the epithelial microflap left and right, and we can see the edematous SLP, and we just take out that edematous part and we reposition the epithelial microflap back. So this is the treatment that should be done because it is the epithelial layer which should be preserved. This is a Rinke's edema. As you can see, this is a Rinke's edema. It is usually on the superior surface, usually bilateral. We give an incision over this, like this, elevate the epithelial microflap left and right. We take out the edematous part and then deposit the epithelial microflap back. This is the treatment that is given for Rinke's edema. Understood? Then there is a papillomatosis. Usually it is the human papillomavirus 6 and 11, which are the culprits. The papillomatosis is confined to the epithelium, and excision should preserve the superficial lamina propria. Most commonly found in musculomembranous region, but may extend into arytenoids, ventricle, subglottis. Basically, they can be found anywhere. The treatment is by cold, microdebrider, microscope, CO2 laser. Resection of the lesion inhibits recurrence in 30% of chronic patients. So as we can see, this is a laryngeal papillomatosis. These are papilloma, irregular parts. So these are the basically, this is a very, very agonizing condition usually seen in children. How much you remove the papillomatosis, it will recur back. And the more the intervention, more the damage to the speech production, more the change in voice, and it won't be able, we won't be able to let this voice come back to the normal size. And it will grow, it will occur again and again. And after 14-15 years, for the reason not known, these episodes stops papillomatosis. So the other name is juvenile recurrent papillomatosis. And in adults, this episode stops by its own. Nobody knows what are the reason. There are a lot of theories, but nobody knows for sure why this happens. That in children, when there is a recurrent papilloma formation, and in adults, why does it stop? Maybe some hormonal changes. Maybe there are a lot of reasons. Theories are there. Yes. Students, any doubt regarding the hoarseness and there are a lot of pathologies we have discussed? You can ask any doubt regarding this. No doubts, or all you all just log in and doing all your daily routine, daily stuff? Students? Nobody is responding. Are you there, students? No doubts? Very good. So the other thing we will discuss is your laryngectomy class is over or not? Has your lecture on laryngectomy has been taken? आपकी laryngectomy पे क्लास हुई है? टोटल लैरिंजेक्टमी, सीए लैरिंग्स, इस पे आपकी क्लास हुई है कि नहीं हुई? क्लास हुई है लैरिंजेक्टमी पे? हाँ? नो. ओके. So my other topic was given to me was voice rehabilitation laryngectomy, but your class on laryngectomy is already not there. I will discuss in brief about the total laryngectomy then. Can you see this PowerPoint, total laryngectomy, laryngopharyngectomy, and rehabilitation? Okay. Now, can you see this? No? आया? Okay. So total laryngectomy, laryngopharyngectomy and rehabilitation. इनकी सी लैरिंग्स पे क्लास हुई है? सी लैरिंग्स पे क्लास नहीं हुई इनकी? अभी थर्सडे को इनकी क्लास है, इस थर्सडे को. स्टूडेंट्स, आपके सी लैरिंग्स पे क्लास हुई है? अभी तक नहीं हुई ना? स्टूडेंट्स, आपकी सी लैरिंग्स पे क्लास हुई है कार्सिनोमा लैरिंग्स के ऊपर? No. Yes or no? Okay. So, so this Thursday I will take class on CA larynx, right? Today I will just discuss just in brief about when you take out the larynx, how do you how do you manage to manage the speech to be for a patient? Like I will discuss this thing right now. Screen दिख रही है? So I will take a class for CA larynx and different surgeries on Thursday, that is from 9 to 10. So, but it is a lengthy topic. It cannot be covered in 1 hour. So I have kept apart that part regarding the cancers and different treatment. But just think that after we take out the larynx, we take out the larynx completely because of the carcinoma. How do you manage the speech production? Because that is a very essential. Otherwise, patient will be like there will be a lot of morbidity. So even after when we take out the larynx, we have certain ways through which patient can speak. Patient can communicate to others by forming a speech. So that is known as voice rehabilitation. So there are a lot of different techniques. The first is, and very old, is electrolarynx. Then esophageal speech. Then there is a tracheoesophageal speech. So I will give you just a brief idea, because at your level you need not go into detail. You should know what are the various ways and in briefly how does it work. So there are 3 speeches: laryngeal speech, esophageal speech and tracheoesophageal speech. First is electrolarynx. You should know what is electrolarynx. Electrolarynx is a instruments which is a battery operated, and it can be used externally. Usually it is used externally or intraoral. Advantages and disadvantages. Advantages as it's a short learning time, ability to use immediately post-op, and it's a low cost and minimal maintenance is required. But disadvantages: mechanical, monotonous, robotic voice. This is the most difficult part because patient has robotic voice, usually a monotonous voice, robotic voice, and patient need to use hand. He has to keep this. This is the electrolarynx, and this upper part he has to keep it in the over the submandibular region. And it is operated by battery. So patient need to keep changing the battery. The cost is around 20 to 25,000. Good company costs around 40 to 50,000 to 1 lakh, all depending on the quality of the electrolarynx. So the mechanism is, the other thing is esophageal speech. In esophageal speech, the trapping of air in the mouth or the pharynx, and patient is trained to propel it into the esophagus, and this esophagus, and through the pharyngoesophageal segment there is a vibration and patient can speak something, although it is not a normal voice, but yes, for a brief point, like for 4 to 5 sentences he can speak before there is a complete gush of air outside. So he cannot speak continuously. After every 4 or 5, after 1 or 2 sentences, he need he need to kind of propel the air again into the esophagus. See, there is no larynx. What is there in the continuity is only esophagus. So whatever he just gulp down is the esophagus, in the esophagus. And after this pharyngoesophageal junction, there is a tight area. It vibrates, lead to the speech production. Other is tracheoesophageal puncture, which is a very good technique. And tracheoesophageal junction, we simply create a tracheoesophageal puncture. What happens is, after surgery, after laryngectomy, there is an opening outside in the neck. Trachea open just outside, and behind the trachea, what is there? It is the esophagus, and we make a hole into that area through the trachea into the esophagus outside, and that is known as tracheoesophageal puncture. So what happens is, we insert a single wall silicone prosthesis into that puncture, and we just we just close the opening of trachea. So what happens is, it is a one-way valve. So all the air, they goes into the esophagus, and through the esophagus and vibration of the pharyngoesophageal segment, speech is produced by articulation. Did you understand what is tracheoesophageal puncture technique for voice production? Students? Yes or no? If no, I can make you understand, I can repeat it once. Otherwise, I will proceed. Just please let me know whether you have understood or not. Anybody? If no, just say it no, and if yes, just say it yes. Okay. Just listen, I don't have this thing. Okay, I will show you some pictures. So this is the picture of the patient after laryngectomy. As you can see this is the opening of the trachea after the laryngectomy. The larynx has been taken out. The trachea just open outside. And through this we can see the trachea, and behind the trachea there is a esophagus. So we make a hole into this. We make a hole into this and we put a prosthesis that is only one-way valve. It means air can flow only through the trachea to the esophagus, but no air can come from esophagus to the trachea. It is a one-way valve. So what happens? Patient occlude outside this area with the thumb and try to inhale, try to exhale. So all the air, they will all the air during exhalation, it will not come out through this hole. It will go to the esophagus, and through the esophagus, that air will come through the mouth. And there is a area called pharyngoesophageal junction, that is cricothyroid area. That's not thyroid, sorry. It is a cricopharyngeal junction, which is basically vibrates, and patient can have some speech production. Now is it okay? Understood? This is a TAP method for speech production. In other method, patient gulp the air through the mouth and patient is trained to send this air into the esophagus, and when this air come out, patient can speak by the just function of the vibration of the cricopharyngeal area. Got it? Pharyngoesophageal junction. This is basically can vibrate. This is the two ways of speech production. Basic mechanism same, entry of air is different. One is through this, other is through this. Is it okay? So what is primary TEP? Primary TEP is when you make a puncture during the surgery. We do not, and when secondary TEP, we make the puncture after the surgery, after say 1 month, 2 months, when the healing is complete. This is the two ways. You should not go into detail. How do we decide? So the best technique is prosthesis. Prosthesis we keep. This is the best thing. because the quality of voice is very good. So the processes can be indwelling, it can be non-indwelling. Indwelling is when the processes stays there, and non-indwelling is when you put the processes, speaks and just take it out like your specs. So this is the provokes. In provokes, this is the provokes pathway. This is what happens is provokes is what happens is the air can only pass through this area into the esophagus. It cannot pass through outside. This is the one-way valve. This is a one-way valve. Provokes is, gives a very good quality of voice. Different sizes depending on the thickness of the tracheoesophageal wall. The numbering vary to A6, 8, 10, 12. It might be 4, it might be 6, it might be 8, it might be 10, it might be 12, it might be 14, depending on the thickness of the wall of the trachea in the esophagus. This is the thing. So selecting processes, we should candidate dexterity, phonatory effort, thickness of the party wall, durability and cost. This is slightly costly. It costs around 40,000 and it stays there for 1 or 2 years, sometimes 3 years. There are different problems for this, like leaking problem, granulations forms, fibrous ring, valve extrusion, aphonia, hypertonicity. You need not go into detail. That was regarding the voice rehabilitation. So this coming Thursday, we'll discuss about the CL larynx and total laryngectomy mainly. Right? Any doubts, bacho? Any doubts till now? Hoarseness, different voice rehabilitation. Okay, Thursday we'll take class on CL larynx. Okay, thank you very much. Bye.